This program is brought to you by Emory University.
Good morning. This morning, we have the pleasure of having a guest speaker who joins us from Cone Health Heart and Vascular in Greensboro, North Carolina, Dr. Kardie Tobb. She is a preventative cardiologist with interest in cardiometabolic disease prevention, women's cardiovascular health, with an emphasis on cardio-obstetrics. Her work also focuses on reducing disparities in access to healthcare in medically underserved populations. Dr. Tobb serves as the medical director and founder of the Cone Health Heart and Vascular Cardio-Obstetrics Women's Heart Health Program. She is also the clinical integration officer at Cone Health Center for Equity and chairs the Health Equity Champions Committee. She's also a business owner, and although we won't hear much about that today because she's going to be talking to us about cardiovascular health inequities, breaking down silos to improve clinical outcomes. Dr. Tobb?
Good morning. Thanks, Dr. A.C. Denso, for that very kind introduction. And I want to thank everybody who's here and to Dr. Mehta as well for the invitation for being here to talk to you guys on something that is very near and dear to my heart, cardiovascular inequities. So without further ado, I'm going to start. But I'm going to start with actually asking the question and try to get who is a history buff here, looking at this monument and telling bare minimum who this person is or where this monument is located. Okay, so this is the monument of Booker T. Washington that sits on the campus of Tuskegee University. So I'm hoping that people know who Booker T. Washington is. And if you don't, raise your hand and we can just talk about it and not talk about cardiovascular inequities. So these are my disclosures. And what I hope to achieve today is to talk about history of inequities in the United States, talk about root causes, especially with cardiovascular disease, go down into possible solutions, because talking about a problem is one thing, but knowing how to navigate and find way to solve the problem is really important, as well as talk about the social determinants of health and talk about possible equitable ways to have cardiovascular care and be able to achieve some type of positive outcomes that we have in the past. So I'd like to start with the reflection of health, the concept of health for our clinicians, and think about what does that mean to you, and also think about what it means to the people that we take care of, our patients, consumers, or if however you like to call it. We think about well-being and we think about the influence of what factors is, but now why is it important? Why are we here today? Why are we all part of the health system, clinicians? Hold that thought and think about what healthcare is. What does that mean to you? It means many things, but I have 4 things here, what it means to me. Thinking about when I interact with a patient, how safe, where I'm coming from, well, how effective I am. Is it patient-centered? And is this timely? Am I doing guideline-directed medical therapy? And am I being equitable? Some people would say, oh, how about quality and how about trustworthiness? Those are important things, but this is what that means to me as we go into it. But now, what is the disruption for all these great things that I think about when I think about healthcare? And you start thinking about what socioeconomic status, you start thinking about what we're facing in the United States, healthcare disparities, and how other racial ethnic groups are impacted, how people of different genders are impacted. So that is really important, and that is not safe. But what that does is, over the globe, it causes a high impact on life expectancy. And this I'm sharing with you just to have a general idea. When you think about places and countries that have higher GDP and higher health spending, there is still higher life expectancy. Disparities comes in different form, socioeconomic status. And I'd like to share with you my reality in Greensboro, North Carolina. And if you can see, that hospital here is where I practice at Cone Health. And if you stand at the road where Cone Health is, there's a 15-year gap life expectancy. So up north, people expect to live about 85. And when you go down south from where I practice, about 70 years old. So that's a huge gap, a huge disparity in a small city. What I'd like to share with you, if you have not seen this data, is your reality. So just here in Atlanta, part of this data was taken from the Emory Health Community Health Needs Assessment that was done in 2022. So here in Atlanta, if you live in 30339, you have 25 years more than if you live in 30314. And if you look at the counties, I may not have all of the counties here, but I just want to reflect. If you look at the counties, you'll see that people living in Bankhead will have a life expectancy of 63 years old. And what I further did to understand your landscape and understand what your population demographics, I saw that in Bankhead, it's about 83% Black or African American or other, and then about 20% white. And then I did see that in Vinning, it's about 60%. So it varies. And that's when we start thinking about demographics, we start thinking about what draws things, we start thinking about where does the conversation lead us. This is not safe because when we think about that, we think about what are the root causes that causes this huge disparities in such a small area or such a wide landscape. One of the biggest things that we as physicians or clinicians have to think about is bias. We think about what's the trust factor. We think about racism, structural competency, and poor leadership. All of these things can lead to health disparities, can lead to inequitable care, can lead to poorer outcomes. But what I want to emphasize today is implicit bias. And implicit bias is something that we all generally have. And it's that first 5 seconds when you think about this person. Am I going to like this person? Are we going to get along? Why does she look like that? What's wrong with her hair? Why is he wearing her glasses? So all of those basic things. So implicit bias can be a positive or it can be a negative. What your thought process of this person leads to how you treat, act, and what their outcome for you is. So I'll share a few things with you. So that's your 5 seconds. So some of you probably, when I came up 5 seconds, you're wondering, oh, I thought she was going to be a little taller. Oh gosh, she's taller than I thought. And oh, she's wearing a dress. So those are all the things. And they're not bad things. It's not going to harm me, but it's just what your perception of me, that 5 seconds. So I share with you a guy who comes into the emergency department. He's 28, and you have a resident who comes and tells you, oh, he's here again. He was here 3 days ago. He wanted pain medicine. He just moved to Atlanta. You know, he's probably moving around. And the first thing you start thinking about is what? He's in pain. So he's likely a drug seeker. He's new to Atlanta, so we don't have any information except for the fact that he was here 2 days ago. He probably told us that his reality is he has sickle cell and he's in sickle cell crisis, but we have no information. So that 5 seconds of what your implicit bias has translated to could potentially harm this particular patient. And then there's another woman. She comes in, she's 57, and she's jittery, and she is probably going through a divorce, but she's telling you that this is happening, and she's short of breath, and she's having some hot flashes. And once the resident, in fact, is the medical student, and says, oh, she's a really nice lady, but she's very nervous, so I don't know what to make of it. And you're thinking there like she's postmenopausal, she's going through stress, she might be experiencing anxiety, and she comes in, your reality for her is probably hormonal, and she's nervous, but her reality is she could be having an acute MI, and we discharge her. Now I'd like to share a journey with you of young Aisha. Aisha was 28-year-old, and this is a case that happened actually in real life. She was 28 years old when we first encountered her. When she came in, she complained of some shortness of breath. And I'm going to walk you through her story. And when she complained about shortness of breath, during the time she was in the emergency department, everything was walked through. As we usually say, nothing was found. But her blood pressure at that time at 28 was about 138 over, I don't remember, but 138 based on chart review. During that time, she was diagnosed with anxiety. She was given a prescription for some medicines for the anti-anxieties, and she was asked to see her PCP, and she was discharged. We encountered Aisha again. About a year later, she came in with some shortness of breath and chest pain, and frequent flyer who usually comes for anxiety, having significant social stressors. So some things were actually recognized. And at that time, she was hypertensive. This time she was in her 140s. So she was given prescription and she was asked to see her PCP. She comes back. By this time, she's actually pregnant. And then she was hypertensive again, and she was asked to see the OB. She was actually starting on appropriate pregnancy-directed medications, and she was discharged. She came back at 7 months. She was preeclamptic. She delivered. And at that time, she was asked to see cardio OB. But during that visit, she complained, after her delivery, she complained about some visual issues. So she was therefore examined and saw hypertensive retinopathy and discharged her medications. She was referred back to her OB, and her OB referred her to cardio OB. So about 6 weeks later, she was supposed to see our team, and she did not show up. So generally, when we have that, we have our social workers who will call just through the Cardiology program and ask questions and, why didn't you come? Is it transportation? Understand that social needs. But we found out that she actually died. She had a stroke and she died, and her mom was left to take care of her son, who's now is about 4 years old. I want you to think about what that means to you for that 5 seconds of potential bias. What are the questions that we did or didn't ask? What are the steps that could have been done that could have prevented some things, or could it be prevented? So those are the questions as we go through this talk today. I want you to think about it. And what could have prevented an early premature death, because she was 32 by the time she died. So what does health equity means to you? To me, and based on the Robert Wood Johnson definition, health equity is a fair and just opportunity for everybody to be healthy, regardless of your age, your gender, your sexual identity, your socioeconomic status. But when we don't achieve that and we have poor outcomes, we have to understand what's causing these differences and what's causing this disparity for us to be able to do what is best to achieve equity. I have a graphical representation here for you. And the real purpose of this is to really look at the word equality and equity. Equality means that you come in a room, you give everybody the same things, and you hope that they use that resource to make the best out of it. And I always, when I hear people say, I see everybody equally and I treat everybody equally. Well, don't treat me like my sister because she's got different needs than I do. I want you to treat me as I am an individual. And that's what I'm asking today. Look at individuals and think equity. What can I give person A to make sure they're able to see the playing field compared to person B? Our reality is some people have more than they need. Some people have nothing at all. We strive to move up to justice, and that is a hard road. But if we can get to equity, then we're working our way to potential justice. Just get to equity. That's very important for us, especially as healthcare providers, clinicians, just people in general. Don't look at me as my sister. Treat me with my needs and give me the resources that I need to survive. We've come a very long way. Another history question. So this picture here, well, I'm sure everybody recognizes Martin Luther King, I would hope, but this is a picture of importance in a significant part of American history. Can anyone tell me what's happening here? Chris, do we have anybody on Zoom that's taking a challenge? It's a quiet bunch. So I like to share that this is actually the picture of President Lyndon Johnson, who signed the Civil Rights Act into law. But this was a remarkable time for American history. This was a great time because it desegregated places and people were able to have a lot of change of where to go and how schools acted and hospitals and people just was emerging into the society. But we still have walked forward, but there's still a few steps backwards when it comes to healthcare and what the outcomes are in different racial ethnic groups. One of the reasons that I always ask myself when I see books like this and when I pull them out to read is 1964 was very important. Why am I still reading about what's happening in healthcare justice? Why am I still looking at these things? So I always ask myself, let's step back into history, because sometimes when we walk into an uncomfortable space, we're able to really see if the glass is half full or half empty. I'm not going to tell you where I stand on that, but it's almost 6.5 dozen the other, however way you look at it. But history is important. And if you can see that when we think about that in the healthcare context and in a medical context, in a physical context, it also impacts what we do and how we think. So going back to the 1900s, thinking about the vulnerability of different racial ethnic groups, just thinking about how admission to medical school and what did diversity look like at that time, that brought a lot of mistrust with different racial ethnic groups. That brought a lot of barriers in communication. One of the ones I like to highlight, if you think about the history of gynecology, when women of African descent were used for experiments, and the part of maintaining pain when we have statements like, and I've heard it before, that, oh, Black women can hold pain. And think about that. Over generations, we've learned that. And we have to start thinking about how do we think about this differently based on the history that translated over time. That really has led to access to care, either people not coming to care because of how they feel they will be treated, quality of care because of the mistrust and because of the communication of perception and assumption. I showed you the pictures earlier. And thinking about healthcare literacy, not really communicating so we can both understand what matters to me or what matters to you. How do we put that together for us to achieve that relationship as a patient-clinician relationship? So that's important. And what about the social aspect of things? Going back again into history lane, thinking about redlining. Why are there places that have different landscape of houses compared to places? And I've seen it in my own city, Greensboro, touring the city, you can see as you drive in different areas. What about looking back in the 1800s, some of those translation of the Homestead Act? What has it done that has landed us here today, thinking about what we now call structural or institutional racism? How can we fight that, or what has that led to? That has led to neighborhoods that are congregated with different racial ethnic groups, neighborhoods that are not built with infrastructure that people can go to parks and walk, and we tell our patients, you need to walk 30 minutes a day. Well, have you asked them if they live next to a walking trail? Can they afford the gym? Is there places that we can encourage people to do? Is it safe? So those are the things that we start thinking about when we do that. Well, why are we, that impacts all of healthcare, by the way, and that impacts everything that we know as physicians and clinicians. That impacts GI, that impacts internal medicine. But why are we focused on cardiovascular disease today? We're focused on cardiovascular disparity today because the projections that we've had for the next 20 years and how are things going to be different? How does that, and we've got a lot of advanced therapies. Think about CRT, think about all the optimized guideline-directed medical therapy. And we do that, we write that, we feel good. But now the question is the patient feeling good? Are we just giving a script like we did Aisha and send her on her way and not think about, wait a second, can you afford this? What can I do? And how can we help you? So what has happened with these projections is really showing that in several years or in 10, or at least projected 2060, we're going to have significant racial ethnic minority disparities, increase in cardiovascular burden. People living in rural areas are going to be affected highly. And then we think about people with experiencing low socioeconomic status is going to be affected greatly. So this is the data from the AHA, looking here at 2016, and I have 2017 here for you. People who are living in rural areas have at least 20%, and you see up here, went up to 40% higher risk for prevalence for cardiovascular disease, mortality, and significant morbidity. So those comes in multiple factors, but one I want to highlight is one is poor access to healthcare, poor access to physician, and then poor access in healthcare provider, meaning that yes, they have an access to a healthcare provider. Unfortunately, they're not getting optimized medical therapy. And then poor ways of understanding. So health literacy has to be be intentional, having conversation, having that two-way conversation, because that's shown that it will hopefully change things as we go with our rural population. And then we go into the racial ethnic groups, looking here from, again, the AHA data showing that 32% of Black adults will die from cardiovascular disease compared to their non-Hispanic Black counterparts, seeing that the average high blood pressure rates, looking at how Black adults actually will develop hypertension at an early age. And I was wondering, no one asked me what Aisha race was, but the depiction of her picture tells you that she was a Black young female. And sometimes when I give a talk, I'll just keep the picture blank and unveil who she was at the end, because that way it keeps us thinking about who she could have been. There's another way when we look at cardiovascular disparity comes in the form of gender. Me as a female will be treated differently as from male. And you think about women really are less likely to have information for cardiovascular disease prevention. And the data also show that women are less likely to be optimized for CVD treatment. So that goes to say that less likely to be referred for CRT therapy, less likely to be referred for TAVR, less likely to be on guideline-directed medical therapy, less likely to have the actual door to balloon time. So that is something that we need to work on as a community. And it's also shown that women are more likely to have a misdiagnosis for CVD. We've seen that in our implicit bias conversation, where a woman comes who is experiencing symptoms that are not textbook or not Hollywood for a heart attack. So the resident didn't catch it. I'm sorry, some residents are on there. I'm not picking on y'all at all. But, and then it comes through the implicit bias, and then the attending didn't catch it, and we've got a missed myocardial infarction. We've got a missed opportunity here. But what I also want to highlight is the difference when it comes to women compared to a Black woman compared to a white woman. Black women has 3 to 4 years shorter lifespan compared to their white counterparts, despite age and socioeconomic status. And then higher risk for heart disease in terms of obesity, in terms of diabetes, and high blood pressure. I'd like to share that by the year 2050, Asian Americans are going to be one of the highest, faster growing race in the United States. And there are growing data on Asian Americans. And I also want to highlight that South Asian within that subgroup actually has the highest burden of cardiovascular disease. And we have to be aggressive in terms of when we're asking these questions. We have to be vigilant when we speak to individuals of that racial ethnic group and not overlook the fact that that person might be 42. I have a personal experience with that, and I know it's a one single case, but it is a case. As a fellow, I encountered a 42-year-old about Asian American male, came in, had a history of diabetes, had just mild chest pain, minimal troponin elevation, and my attending, whom I love, was also Asian American, a South Asian American, and I'm talking to him. I'm like, oh, you know, he's here, just mild chest pain. He has diabetes, and I was a great first-year fellow, and I'm talking, and he stopped me and said, Dr. Tobb. I said, yes. He said, what do you want to do? I said, send him home. You know, I'm thinking in my head, duh, it's obvious, like he doesn't have the thing. And then he looks at me and he said, I'm glad you're a first year. And I thought, and he said, we're going to count them. And I'm thinking like, geez, like very aggressive here, buddy. But I followed everything we had to do. And he had an 80% mid-LAD. And he was stented that day. And after the fact, I looked at him, I was like, wow. And he started to tell me, he said, well, there are data that's improving and as we go along, but he said, those are one of the groups that you want to be very careful about when it comes to cardiovascular disease in the young Asian Americans. So I really want us to hone in on this as well. What's happening with our Hispanic population? So there are data before that showed that there were lower cardiovascular risk in people of Hispanic origin. Not until the San Antonio Heart Study that showed 60% more CVD risk in Mexican Americans at the time, because that was the population that was there. And what we found out later that two things happened. One, their data was underreported in Hispanics. And two, most Hispanics will go back to their country of origin if they have an illness, if they're having a near-death experience, to likely die in their home country. And that's why we don't see that mortality rate as we do, and it's not reported in the United States as it should. So we've talked about some of the things that we expect. We've talked about what we need to do in terms of being aware. Why are we thinking about this on the long term? So this paper in JACC really looked at the progressions for cardiovascular disease from the 2020 census tract data and projected that by the year 2060, we're going to have an increased risk of cardiovascular disease, and we're going to have 39% diabetes. We're going to have about 27 lipids, and then we're going to look at that progression over time with ischemic heart disease and myocardial infarctions. But the most important thing that I want us to take a look at is down here, where you see that disproportionately is going to affect racial ethnic groups. And I've also just highlighted the African-American race and highlighted our South Asian race. So we cannot forget that this is projecting and this is the time to act. So since it's a projection, that means we have the ability to alter what that can happen if we just do a few things and work together and see people equitably and be able to help people with resources that they so need. What are we doing now? Now we look at this in different approaches. And every time I read something, I see what can the patient do in order for us to work together to have equitable outcome, much better outcome. First thing is the patient has to come. There has to be a trust factor. They have to build. And when they come, we talk about their preference. How are they seeking care and what are they going to do? Because sometimes we can do everything we need to do, and the individual will not do what they need to do. So that relationship is not going to work. The outcome is going to be the same. How can the health system help us? There are a few things that we can do as clinicians. You think about that 15, 20 minutes, sometimes you're like, a few things to say, I just want to just do this. And you're thinking about like, you already have 3 people waiting and you walk out. I don't know about you, but like your nurse give you that look like, you got add a little more pep to your step. And I'm like, all right, I'm on it. And then you get to the next patient that really need that time and you're thinking, but how can that improve? How can clinicians be able to have that time to be able to give the care to ones? And where are we in different geographic locations? And I'm saying that there's a 15-year gap, and I'm saying that there's a 25-year gap. Where are hubs? Are we thinking differently on how we care for people, or we just have our brick and mortar structure and just doing what we need to do? So there are multiple things that come in play. And here where we stand, how do we contribute? The first thing I like to say is let's try to intentionally, when we're starting to get that bias and say, oh, I don't like her hair, just think about, oh, she likes her hair, so that's fine with me. How can we be objective and work together as patient and clinician and really get that outcome we need? Stop thinking about some of the things that we've learned. And sometimes learned behavior are one of the hardest things to really condition yourself to not do. Like, how do we intentionally go along with that and try to change the way we think for the positive outcome that we need? Is that all? What else can we do? What are other things that we can really include in our care to help individuals that we take care of? From my perspective, where I stand here, I think the social determinants of health is one of the single most group of things that causes the poor health outcome that we see, that we as healthcare clinicians need to partner and work along and first try to understand what do we do and how do I get this in such limited time? Is this a team approach? Who's involved? How can the healthcare system help? And who else can we get to the playing field? So there's a paper in JACC last year that shows, it was a JACC state-of-the-art paper that shows social determinants of health, direct impact, and what can a healthcare system do, and what can clinicians do? So how do we assess it? It's not all of our problem, but we need to be involved with this. And when we think about the financial burden for social determinants of health, people experiencing homelessness and their healthcare costs comes up to about $1.5 million. And then when there's lack of transportation, access to medical care, that burden goes up to 3.6. And now the simplest thing that we think about every time, and I reflect on this every time I'm taking something out of my refrigerator and trash, and there are many people experiencing food insecurity, and that highly impacts their care, and especially their cardiovascular care when you think just on a simple line of diabetes. Most of the people who are getting foods from food pantry, we're doing a good job to give them places, but half of that may or may not be really good for their diabetes, and those things are not known. So 80% of what we do and of our outcome is based on what happens with the patient's social unmet needs. And one thing I'd like to highlight here too is there's a paper that came out right after COVID that showed that SDOH needs, that's highly needed in a primary care provider, significantly their patient population increases burnout. So it translates not only to the patient, it translates to us as physician, because what that was showing was as we kind of go through the process of care and transaction, where it increases that stress on how do you care for your patient, and that increases physicians' burnout. So what can we do? The power of data. How can data help us? You know, I read a article one time, and the person reflected on Edward Deming when he said, you know, in God we trust, but all others must bring data. And that is so important. And I always use that trust but verify. So that is so important, right? Because if you see the data, we're all scientific people. We want to see the numbers, and we want to see how it shifted. And how many of you have been in a meeting and said, like, I don't understand how they got that percentage? Because that's who we are and that's how we think. So let's use our strength to be able to help our patients. Once we want to be able to identify where the disparities is based on data, we want to be able to look for resources, and we want to be able to measure what we can do, look at the interventions. The best way to do that is getting your data based on race, ethnicity, and language. And if you're not doing that now, that's a practice that you start, because that's going to help you see the loopholes of which groups that we need to focus on, which zip codes we need to focus on, how we're doing this better for this group, because sometimes we can do something better for another group and create disparity for the other group because we're doing a one-size-fit-all package and we're not customizing that care based on, and it can be the same group, and it can be, for example, it can be a group of Hispanic women, but because their needs are different, we can actually create a bigger disparity. We work in silos a lot of times, because you can, one person will be doing something here. I imagine you guys have 7 hospitals, and a group will do something different here and do something there here. And we're all thinking that we're working along, but we've created a silo. And what the data would do for us, it will unveil that. We'll be able to see, are we doing redundant work? Do we really need to? Are we causing more poorer outcomes? We're not communicating. How can we communicate so your great process that you've innovated, I'm able to adopt that with like minor changes? Is there going to be some error because we're both giving the same information, but in different ways, it's being translated differently? So we need to be able to take a look at that. And in order to do that, we have to work together. It's basically, what are we doing for these social needs? Are we addressing it? Are we finding ways to be innovative for interventions? Are we looking at it? Because there's one thing that is true. It's the fact that we already have a group of patient and a population that already don't trust us. You know, those distractors that always will be there. And all they need is one good person from the influential bunch to tell them that is a problem. And now it spreads. And then we have a bigger problem than we did before. So we need to be able to work together. And one of the biggest thing I like to do, I'm called the optimist a lot of times on our meetings, because I'm like, what if we did this? And I'm full of reality in the sense that I know this is optimism, but how do we work to achieve something closer to that? What if we had just in a system that each healthcare point is well seen, that every point of that patient visit? Have you ever had a patient that you walk into their room and you ask them questions and they look at you like, well, it's in the records, and either it's not clear or something, and you're looking like, how do I come back from this? You know, and just work the way through the person. So how have we had a data that was at least close to the truth as much as possible, that when we walk in and we can say, well, based on the electronic records, I saw this, this, and this. Can you confirm? You know what I mean? Because we're doubting as we're going in and we need to confirm from them, and they're looking at us like, she don't even know what she's doing. So a lot of times I've experienced that. If you haven't, that's really good. But think about our communities. How do we get our community-based organizations to support us? We can't be in this together or alone. We have to do it together. We have to, because we're a healthcare entity. We will give you the healthcare, but we can try to give you the social needs, but we need our community partners. And that's why it's important. There's not one single person that's responsible. The clinicians are responsible in a different sense with the care team, the care providers. So that includes the clinicians, that includes the social workers, that includes the community health workers, that includes the CMA who rooms the person. We all have a part to play. It is a team sport. And then the healthcare system. We've seen what the usual thing is, but how can we think differently? What makes this different for us that we can be able to say, well, we did this, and we do this all the time. How can we tweak this based on the healthcare system? In the community-based organizations, they can't just say like, oh, Emory, you got this. No, it has to be a partnership. You're coming to the table with those social needs that you need to help us address. We've got you on the healthcare needs. So that's why it's everybody's business. I'd like to share with you a few strategies and some way of strategic thinking about social determinants of health, just focusing on how we address the social needs. You know, thinking about just having it, because I'm sure that you guys have a platform that people can ask the questions for the SDOH and things like that. How is that platform connected to an outside world in terms of, are you sending this referral to a place that lands and actually act on it? Are we integrating our innovations and interventions that we do as part of this plan when we record for individuals? Are we actually being intentional to really have cultural humility training? Not just the DEI thing that we do, but actually have specific cultural humility training, thinking about, okay, for example, this is the reason why I'm doing this, because I know that there are authors here from the paper that talk about the diversity in Black women. So I'm gonna respect them and actually talk about that. So think about a Black woman. So we come in all shapes, sizes, and forms, but when I say that, we come in different ethnicity. So there's a Black woman who was born and raised in the United States. I'm a Black woman who was born and raised in West Africa. Now it's up to you to find out what country, but I come to the United States, but I'm a Black woman. There's a Black woman who was born and raised in the Caribbean. And there's a Black woman, like my kids now, who are first generation Americans. My daughters will be a Black woman, or my daughter, one of them, or both of them, will be a Black woman who was born in America, raised by immigrant parents. And their experiences will be different. So their cultural sense will be not conflicted, but very rich and enhanced in different ways of how they see things. So we always, and that's the same things, right? When you think about people, non-Hispanic Black women, right? You see a woman and you say, oh, she's Caucasian. Well, she might be Italian. She might be Australian. She might be British, you know? So we think about all of that, and we have to be able to be culturally sensitive. One of my favorite things to do is when I walk into the room when there's a French-speaking person, not only because I want to show off, and I go like, bonjour, because that way we've really broken that part of, oh my God, she knows I speak French. Or, you know, when I walk in the room with a Hispanic person, I say, hola, you know, things like that. But it just creates that sense of, wow, he or she is trying. So those are the things that I like to share with you. And our community-based partners, to them, it's not the time for them to say, oh, Emory has a lot of money and they need to bring some of that money to us to do things. I think the conversations should be now, how are our goals aligned? How can we make sure that we can support you? Even if you bring financial resources, that is fine. But the first thing is let our goals align. Let's figure out how we can expand the resources and we can work together and we can be able to, importantly, track those outcomes. Because if you're doing and doing and doing and you can think about the data and show me what it's doing, there's really nothing much there to show, you know? So that is so important. And us as clinicians, what can we do? So like I said, it's a team sport. So we have to be looking at individuals that don't have these needs and how do we refer them, thinking about outreach sometimes with the community partners and be able to, one of the important things is how do we recruit people of diverse backgrounds. So sometimes it's the health system business, but at other times we have to be able to see a talent and say, I want that person on my team because the population that we serve look like them. And that is important. So with that, I want us to reflect on this quote and this phrase here, because this is an ethical responsibility for all of us. We need to strive for it. We're not going to go without failing. We're going to fail. We're going to just do a few things and it's not going to work. Be okay with that. But I think one of the most important thing is, if it doesn't work, what are you going to do about it? Are you going to walk away? Maybe you need to, but are you taking that energy and transforming it into a different intervention? Are you creating another team? Are you being resilient? What are you doing about that? I'd like you to reimagine Aisha's story. Now we've worked our way through all of these and think about these steps that could have been put in place to avoid a premature death. She comes in, she's hypertensive, she's given a prescription, but she's tagged on with a social worker because somebody didn't just give her the thing and said, go ahead and see your PCP. One of the most important questions that we were at dinner last night, and I asked one of your colleagues, and she said to me, Christina, and she said, you know, we try to get people to a PCP. And I asked her, I said, do you refer them to the PCP? And she said, yes. And that just kind of warmed my heart because we always say, go and see your PCP. And sometimes we don't stop and think and say, do you have a PCP? And that was the question that was missing here. So once that was answered, she went to see that PCP that she was referred to. She got her blood pressure checked. She didn't have transportation. There were mail order medications that came to her house. And when she got pregnant, she had transportation to see OBGYN. She had her baby, was connected with a community health worker. And after her baby was grown, she got a job and she's still here. Imagine that. One question could have prevented, I don't know, somebody's probably on the line like, Tobb, what are you talking about? Maybe that was her time, I don't know. But and those are people who believe in destiny. If it happens, I mean, it is the time. But think about that one single question could have, without implicit bias, changed the life of this young lady. Not blaming anybody, but this is an opportunity for all of us to learn from, to grow from, to be able to, every time we're intentional to change that landscape. Here's what I like to leave you with today. Let's change the narrative. We've seen a difference in when we change the narrative, what can happen. We can avoid poor outcomes, premature deaths. Let's partner. And we don't need to know the people that we partner with all the time. The goals just have to align. Because sometimes people say, well, I don't know that group. What's there to know? Figure out how you guys can be aligned, set common goals, and move from there. And if you're going to be friends, and you can be friends after, but it is for the community. Figure out sometimes how your goals align or create new ones that's going to be beneficial. I also like to say, make sure you are checking the data because you'll continue to work, you'll burn out if you don't check the data to make sure that you're going to the right direction. It is not going to work out. And lastly, we want to be able to prioritize equity and those interventions for unmet social needs, and that's going to be important. I'd like you all to really challenge and understand from your organization, where are you now? Thank you.
Thank you, Dr. Kardie. That was absolutely fantastic.
You're welcome.
And thank you again for, calling in something that we think about, but not in this way. So thank you for that. Questions? I'm going to open it up.
Thanks for that great talk, Dr. Tobb.
Appreciate it.
You know, one of the things, as you mentioned, social determinants of health and disparities in cardiovascular disease, especially among women, I find that most of my patients now are much more informed than probably 10 to 15 years ago. They come to me knowing what some of the medications for heart failure are. They ask about some of these advanced therapies for lipid management. And yet, amongst women, we know that still less than 50% of them are aware that cardiovascular disease is a leading cause of death. So I guess my question is, at the patient level, what do you think we need to do to improve this awareness? Do we need to communicate with women using a different medium? Are there campaigns that you've seen that work better than others at this time, now that most people are on social media, et cetera? Because all of this is leading to cardiovascular disease disparities due to late presentation and poor recognition of symptoms.
That is actually something that we have been working on. Thank you very much for that question. So I want to reflect back to the Go Red for Women campaign. I have a talk when I do women's health, and one was back in, there's a magazine cover for the Reader's Digest. Does anyone know Reader's Digest? Oh, come on, y'all. Please, you know Reader's Digest. But on one edition of it, it says, how to watch out for a heart attack in your husband. And then decades later on Time magazine in the 2000s, it said, heart disease in women, 1 to 3 is affected. So education is so important. And when you look from the time, the AHA data in their graph show from the time of like early 1900s going down to when, I think 2002, when the Go Red for Women campaign started, and then mortality decreased for a while because there was a very aggressive awareness and education. And recently it's starting to creep up. So one of the things we're doing is creating different champions in different areas of education. And we do our annual community women's heart symposium or community event where we're educating women, and through that we have connections to go to different areas. So one of the biggest things that we are trying to do is meeting people where they are, going to the different areas and educating, and then making sure that we have a champion from that area. And Women's Heart does it very well too, and they have different champions. But what we're looking for is doing the preventative championship, because a lot of times Women's Heart is a person who's already have disease, but someone who's working towards primary prevention. So that is important. The education is important because people will listen to the person that they've grown up with, of known for a while, before they listen to their physicians, and that's just the reality. So yes, education is important. Any other questions? Yes, ma'am.
So I wanted to ask about, you mentioned community partnerships, if you could speak to which ones have you've had some success with partnering with. I saw like faith-based brought up there and education, but just curious for you to speak to your experience with that.
Okay, so as Dr. Incidenza mentioned earlier, I wear another hat in our organization with the Center for Health Equity. I'm our clinical integration officer. That just means I do a lot of work. That means that I'm the physician in the center that work along with our teams to make sure that we're creating innovative ways that we can reach the community, and not just creating those with making sure that they're safe and there's equality and we're able to track the data. So with those, we have our Catch 5 and 5. What that means is collaborative action towards community health. And we work with different, so one of our unusual partners is the Greensboro Housing Authority. So we're working on ways to create digital access to primary care. And then we work with faith-based organizations where we have different programs, and we have one of our community health workers who does in the rec center bring dietitians and things that do cooking classes. And we have our mobile units that go to a lot of different places and screen. And the most important part of that, working with those community partners, we're making sure we're connecting people to primary care. But yeah, so we have various churches and various mosques that we work along with, and then community rec centers. Mhm. Any other questions?
Quick question.
Yes, ma'am.
I was interested in your thoughts about, when we talk about disparities, we also look at just a map of United States, and Southeast has been, dark for, yeah, I mean, since I was
darker
in
and
med
dark
school,
blue.
darker and darker when it comes to, and so I'm just wondering about your thoughts about that, because it's been like that. I mean, it was like that when I was in med school. It's like the same, that Southeast is, leading. What do you think about, what are the reasons? Just want to get your thoughts, and then what can we do about that?
Some of the things that I think about when I think about the Southeast region of the United States, it's heavily rural. There are cities, and I'm not trying to say that it's all rural, but there's hot cities in the Southeast region, but most of the counties are rural. So that's one of the things we have to start thinking about. What access do we have in these areas in terms of well-trained PCPs? We were talking again last night, and one of your colleagues mentioned that, for example, there's a shortage of OBGYNs. That's one of the things. And then I can't really speculate on what the access look like in terms of community resources. But I think that's one of the things that needs to be assessed is what are the community resources? I'm not talking about the community building that all the kids can go and play in the back and then run around and say, oh gosh, we've got community resources, we've got the YMCA. I'm talking about how are we using those resources for the common good in terms of adjusting healthcare experiences in that area. For example, creating a hub in a church somewhere where individuals who already go to that church without a PCP can be able to say, okay, Wednesday night is Bible study, but we're going to be also having a primary physician come in from 7 to or from 6 to whatever time. Creativity. We cannot continue to do healthcare the way we did it of 10 years ago and how we do it now. We have to be open to, I call it doctoring differently. Where are the unusual spots that we see people, and how do we improve that? Yes, sir.
Thanks so much. I was curious to go back to your question a little bit, or the earlier question about some of your role as integration officer, thinking about kind of how you develop and prioritize programs. And you mentioned sort of being rooted in data. What kinds of metrics are you guys using to look at what programs work, which ones are worth investing in? I mean, I think especially in the context where, it's hard to get incentive structures to align to things that we actually would all like to see happen. It's really important to find which programs are particularly high value. So I'd be interested in your approach, how you guys have thought about rolling out programs in ways where you can figure out sort of what's making an impact.
So some of the things that you just highlighted is one, sometimes equity work requires capital. That's not going to give you all the beautiful word that the people who are in accounting like, the return on investment. So then you have to start thinking about what does that mean for return of health, and how are you projecting it based on your ED visits, and how are you looking at unexplained clinical encounters? Meaning that, okay, so I'm going to see you in 6 months, you're here in 2, what is going on? And also looking at, and that includes like your urgent cares and things like that. And start looking at what we call health equity measures for different metrics. How are we doing in our Caucasian population, since we've been doing this, and in our Black population, in our Hispanic population, and start setting targets, because we've done that with hypertension, we've done that with cancer on the different levels. So those are the things that you really put together for your return of health, because asking for a capital that's going to be sometimes in the tune of $500,000, and you just hope that you avoid a CFO for a couple of weeks. It can be hard, but you have to think about it. And then also, I think that the mindset of the senior leadership on where do they see the organization in this community in, for example, let's pick on 2030. Like, what's that 2030 vision? How are you adding that to your vision and saying that, okay, we're not doing this way. Where are we going as a country? And really, where are we going as a health system? What side we want to be on? But you're right. Those are the things that we deal with all the time. I don't want to say deal with, but those are the challenges that we have to be able to really explain. How is it? And people have asked this question, how is it different? And sometimes you really want to say, like, it is really different. But yes, I do get your point that a return on investment is going to be tough, but let's focus on, AMA has a very good, the American Medical Association, have a very good article and very good way of teaching you how to understand the return of health and how to put your interventions and projects based on that. So I'll refer you to that too, if I didn't answer your question. Do we have anyone online? We'll click on the chat. Oh gosh, yes. We've had so much question on so much fun in this room that you guys are missing out. We've got breakfast here. Okay, so signs of voting. Oh, okay. Oh, hey, Dr. Ogune, how are you? And I see your question here. If you want to, can she unmute? Yeah, you can unmute and ask your question, please.
Hey, Dr. Tobb, thank you for that inspirational lecture and call to action. So in everything you mentioned, I was wondering what your thoughts are on the role of advocacy and policy change to decrease disparities. You know, you mentioned a lot of multi-sectoral approach, but I think that there are some things that without advocacy and policy change. So what is the role of the clinician? What is the role of community-based organizations, like you stressed, in decreasing disparities?
So I'm very grateful that you brought this up, because it was going to be really unfair not to talk about this in this sense. Most of what we do are based on different policies, and that trickle down effect really takes place on those different levels. And the reason why I say this is because, as the chair of our health equity champions at Cone, one of the things that we started to look at is our organization policy. And we found some of the policies were made by people without very valid reason, but more of a sense of containment. So for example, there was a policy that if, and this is not cardiovascular now, it's maternal health, but if a mother did not get prenatal care up until the second trimester, and once she delivered, the baby was taken to a place and the mother was drug tested, and it would turn out, looking at the data, that it really was affecting most young Black mothers who did not have health insurance. And by the time they waited for insurance, that time came and they didn't know that it could call and be seen and things like that. So that's one of an example. And all the policies that affect individuals, that different health system I've heard of have, that said, okay, if person is not going to show up in 3 of their visits, we can't see them anymore and things like that. So on a health system level, we really have to look at this. And by the way, if you guys don't have a committee here at Emory in terms of health equity, I probably won't be invited back again but I will say this, you need that, because what our committee does, our champions, is physicians from different specialties, and that also includes administrative partners. And we're looking at this in a different light. So looking at those policies, and then that goes also to the policies that in local governments, right? We don't have jurisdictions there, but we have, and I can't say this without giving one of my colleagues, Dr. Olujegede, who is our vice president for health equity, his credit here. He's formed something called Heal Greensboro, and we're working along with different community leaders to look at just those things and understand how is it impacting our community and what are the policies in place. But yes, advocacy for policy change really starts from our level as the clinicians and kind of go up from the community and things like that. So I'm grateful that you brought this up, because that's very important.
Well, thank you again, Dr. Tobb, for a wonderful presentation. We've learned a lot here, and I think you've charged us with looking at things differently clinically and to focus on advocacy and championing for our patients as we do every day. Thank you, everybody online who joined, and we'll see you next week.
Thank you all. I appreciate being here.
The preceding program is copyrighted by Emory University.